It's Jessica. I'm here to talk to you about Seeking Saftey, which is a manualized evidence-based treatment for PTSD and substance use disorders. It was originally developed in '93 by Lisa Najovitz, and the majority of the work that I'm going to be talking about through this group is going to be coming from here, and a lot of the research is from the websites and a lot of other areas there. So let's dive in. We know that post-traumatic stress disorder and substance use disorder are highly related. They often come together for a lot of different reasons. Often we use substances to numb out intrusive thoughts, feelings, emotions, anxiety, and so seeking Saftey as an evidence-based treatment is very key to be working in the interrelationship of those two things. It's been proven to be successful in multicultural settings, including homelessness and criminal justice and domestic violence, people that are severely mentally ill as well as highly functional. And a lot of the newer research is with veterans and military, and some extensive research on Aboriginal groups as well, which is fascinating and awesome. So it's diverse and there's multiple languages. If you would, I would pull up the handout that I've included. I have included links throughout the handout to lead you straight to those things. There is extensive information, so there's so much to read. I'm going to try to keep it really short and sweet. I have my timer on me so that I don't go over time and bore everyone to death. Okay, so why do we need this group? Like I said, the dual diagnosis of PTSD and substance use is common. We know women experience trauma more often. This was originally for women and has broadened out into all populations, men, women, LGBTQ, adolescents, children even. So there's a lot, it's very broad, it's used very flexibly, which is kind of cool. So offering an integrated model is recommended because we know if we resolve one, we're going to have the other still, and often it's amplified. Resolving substance use disorder can increase the severity of PTSD symptoms and vice versa. So working together and having the client understand a relationship of those things is key to long-term healing, which is really cool. So we're going to go into starting a group. I have organized my starting a group as if you were sitting in maybe a community setting, community mental health setting. If not that, this would still apply. These are some of the guidelines that are mentioned throughout the manual and implementation. So, and I have included how to implement the group with a link there as well. So I'm going to note you want to start with a co-leader most likely. It would be helpful to have a support system, to have someone that you like, and you read through all of Seeking Saftey materials thoroughly, knowing what you're getting yourself into, what you're going to be covering, the important parts of it, and then decide on group features. What is it, gender specific? Is there a specific time you're going to have it? All those just nitty-gritty details are really key as well. How many weeks are you going to have it? Now, I'm going to get into a little bit later, but they have 25 topics here. You don't do all 25 topics unless you want to and you have the time for it. Typically, this might run an 8 to 12 weeks, so you're not going to be doing every single topic week. So decide what you want to do, and also decide, are you going to be, what kind of severity of clientele are you working with as far as symptom management. I've included the ASAM criteria there if you have some confusion about severity or you're thinking about what this client might need. I think that's a really valuable resource. And then you want to start by getting flyers out into the community setting or community services, whichever you decide to do. You're screening your clients for a dual diagnosis. However, you don't have to have a dual diagnosis or have even a full criteria of either diagnosis to partake in the group. It depends on what you're doing, but it's not necessary to have a DSM full-blown criteria for PTSD and substance use to participate. So you're going to inform your group members of their spot and their participation. It includes community meetings. It includes attending outside meetings and working with sponsors and things like that. So having some commitment is important. Inform your group members of their spot and participation, like I said. And then what you're going to need to do as a leader is attend an AE meeting, an NA meeting at least once, but preferably more, in order to thoroughly understand 12 steps and how that works. I'm going to move on because I've got a lot to share. Key principles and goals. Safety is number one. As you know, with your counseling, PTSD in particular, if the client is not in a safe place, you cannot process PTSD. It's the same here. So the overarching goal is safety, and that means relationships, their thinking, behavior, and emotions in and outside of the group. It is really key to have resources available, and that is another part of that we'll get to in a moment. Integrated treatment, obviously we're working on both things at the same time. We're talking about how these things relate, and focus on ideals. So how to counteract the loss of their ideals in both trauma and substance use, and bringing back some hope and some positivity into their life. And then the 4 content areas are cognitive, behavioral, interpersonal, and case management. And that's going to go right into our group theory and techniques in just a moment. Attention to clinician process is probably the most interesting and unhelpful thing to really think about at the end here, because your countertransference is real, and research supports that there is more countertransference with clients that have substance use disorders. So paying attention to that each week, noticing what's coming up for you, having good self-care practices is emphasized throughout the program and implementation. Okay, like I said, group theory is CBT as well as interpersonal and case management. So there's a good portion you're going to be doing different cognitive behavioral things. A third is about interpersonal theory and how to bring that into how substance use and PTSD has affected relationships, how they've been wounded, how they wound others, how they trust, how they have boundaries, things like that. And then case management is throughout. You're going to be giving resources to your clients as needed and being prepared to do that. So group topics, if you swing down, you'll see there's 25 group topics, and that's a lot to cover. You can read through that list, and there's a brief description of all of them. You can click through that. Let's say you're not going to do 25 topics. Which one should you do? You'll see the recommendation is a few there, like safety, number 1, taking back your power, how substances control you, grounding, which is detaching from emotional pain, and asking for help. So those are the ones that are fully recommended no matter how many you do. And I'll move on. Group format. So the group works like very structured, and there's a group check-in. Each member gets 5 minutes tops, and they're going to be asked, can they identify an unsafe behavior that they've done this week? Can they identify a good coping skill they used? And then describe a present feeling about being in the room in the moment. So it's a lot of here and now, keeping the clients in the here and now throughout group time. And then there's a quotation. So you'll use, each week has a different quote, and that's really interesting. So you'll have a member read a quote, and it'll generate some thoughts and feelings and say, what does that mean to you? Or how is that connected to what you're learning right now? And there's lots of really fascinating ones and insightful ones, and some that feel really painful to look at as well. Relate to the topic to members' lives. So what then you're doing is, as that quote starts generating conversation and starts to generate some feelings, you're going to start to connect the handouts with that and making it make sense in a practical way. Each week you have handouts for your clients and for yourself. It is very structured. You're going to be going through something that feels in depth, but at the same time, it feels like you have something to fall back on if you get stuck. And then checkout. Ask, name one thing you got out of today's session. What's your new commitment? Now, commitment is another word for homework. So we don't use jargon in the group. So having that, there's different words you're going to use, like commitment or thinking rather than a cognitive distortion, for example. And then I have a link right there to the group implementation guide. That is going to be super helpful. Go look at it. It would be helpful for any group you do. Ethical considerations. Informed consent, obviously, and matters of confidentiality in the group. Corey and Corey cover that. We know we've been talking about it consistently throughout our course. And next, Develop safety plans for client risks. This is a high-risk population. So knowing your clients, do they have suicidal ideation? Are they self-harming? Do they need resources to have HIV testing? Are they at risk for overdose? Are they in a DV relationship? So you'll be needing to do a lot of case management around some of those things. Other ethical considerations, counselor bias, and being aware of your biases and how that might affect them, getting your own supervision for that, and having attention to any countertransference, preparing well, making sure you are prepared to mentally, emotionally, and just ready to give the group stuff to everyone. That's really key. And then establishing a group policy of member contact outside of session. Members want to get outside of session, having, that's my timer. I'm supposed to be done right now. I'm going to wrap it up. You can read through some of these things. Some of the anticipated issues and member roles, you can read through there. Some things that are key overall in this group is that this is not an in-depth trauma process group, and I think that's the takeaway here. There needs to be respect that that trauma stories are not gone into in depth because it can be very triggering for others. That is specifically for individual counseling. So as you read through all of these things here, hopefully that'll be giving you a lot more information. I've included links at the bottom to training is not necessary, but it's offered. Peers can run the group if they want to, but if you want to learn more, you can go find that training. And if you want more research studies, you can click to their links, which is really helpful. And I've included my own resources. Hope that's been helpful, guys, and I'll see you in class. Thanks, bye.